I'm delighted to welcome you to the Exchange Critical Conversations with Michigan Public Health. I want to thank all of you today here joining us live in the audience. We also have a number of people joining us via live stream, so welcome to you as well. And then I want to extend a warm welcome to our keynote speaker today, Dr. ASHISH Jha, and to our esteemed group of panelists who you'll hear from later today in the program. We're really honored to have all of you with us. The Exchange is a new seminar series that we launched just last year with the primary goal of creating a space where community partners and other external stakeholders can join together with students, staff, scholars at Michigan Public Health to discuss pressing public health issues of our time, to exchange ideas, and to ultimately influence and accelerate a course of action to create a healthier, more equitable world for all. The theme of today's event, disrupting infectious diseases, fighting for our future. By design, this is a core topic in a research initiative in the School of Public Health that's called Public Health Ideas, where IDEAS is an acronym that stands for Interdisciplinary Discovery, Engagement, and Actions for Society. Over the last few years, we've launched several IDEAS topics, and they are public health ideas for creating healthy and equitable cities, public health ideas for preventing firearm injuries, public health ideas for building health equity, and public health ideas for combating infectious diseases. So today's event aligns with the infectious diseases theme in the IDEAS initiative, which is led by Dr. Emily Martin, who you will hear from throughout the day. I want to thank Emily for her leadership, and as well, Laura Thomas, who's manager of the Michigan Center for Respiratory Virus Research and Response. We have a fantastic program established for you today. Throughout the day, we're going to delve in just to the latest of infectious disease research, innovative interventions, and policy making. We live in a global world, and as we know, infectious disease threats in one location can impact all of us. We certainly saw that play out with COVID-19, and as COVID continues to challenge us on a global scale, we also grapple with other infectious diseases like avian influenza, Mpox, and Marburg virus. Infectious disease threats are always present, and it's not really a matter of if we will face another pandemic-prone virus, but the question is when. While this can seem daunting, there are things that we can do. First of all, I'll say that I have confidence in our people. Those are the frontline public health workforce, the scholars and researchers who can help to protect us and provide evidence and guidance during infectious disease challenges. And then secondly, we know the benefits of preparedness and of aggressive, strategic, and coordinated response efforts. There are so many lessons that we've learned since the start of the COVID pandemic, and today we'll talk honestly and openly about strengths, but also weaknesses and how we can best prepare to combat the next infectious disease threat. We'll start with a keynote speech from Dr. Jha. Following that, he and I will sit down for a conversation to delve deeper in the topic for today. And then we have a tremendous panel of experts who will discuss the work happening on the ground in Michigan to combat infectious diseases and the ongoing research taking place at Michigan Public Health. And then finally, for those of you who are here joining us in person, we hope that you stick around for lunch and a research showcase as well, which will be just down the hall. I want to once again thank all of our presenters and participants, and I also want to thank our marketing and communications team for coordinating the day. In fact, let's, to start with, give them a round of applause. So with that, we'll move right into the keynote. I'm thrilled to have Dr. ASHISH Jha with us to deliver the keynote address. Dr. Jha is a global leader driving public health research, policy, and practice, and he serves as Dean of the Brown University School of Public Health. He's an accomplished and practicing physician, recognized globally as a trusted expert on major issues facing the nation's health, and a catalyst for new thinking and approaches. He's a longtime leader on pandemic preparedness and response, from directing groundbreaking research on Ebola to serving on the front lines of the COVID-19 response. President Joe Biden appointed Dr. Jha as the White House COVID-19 response coordinator in March of 2022. From the White House, Dr. Jha led work that increased the development of and access to treatments and newly formulated vaccines, dramatically improved testing and surveillance, rebuilt our strategic national stockpiles, facilitated major investments in improving indoor air quality, and put in place an infrastructure to respond to current and future disease outbreaks more effectively. Dr. Jha, we're delighted to have you. I'd like to welcome you to the stage for your remarks.
Thank you so much. All right, good morning, folks. Good morning, folks. Good morning. All right, let's get a little energy, Monday morning. Dean Bowman, thank you, and really to all of you who have organized this, Emily, Ann Riley, who's just done an extraordinary job of keeping us all on track. I am delighted to be here. I love Michigan. I feel like I have so many colleagues and friends here. I was telling folks last night, on Saturday, my Twitter feed just gets filled with Michigan football. I feel like I know Michigan football better than any other college football, including Brown football, and that is all of your faults. So I'm going to speak for about 20 minutes or so. And my only ask is that you don't walk out after 10. And that's because in the first 8 to 10 minutes, I'm going to get you a little bit depressed, a little bit anxious about the period we are entering. And if you walk out at that moment, you're going to get, I think, a very potentially concerning view of the situation we're in. But then if you stick around for this next 10, 15 minutes, you'll hear a path out of the challenge that we are facing. But I want to start off by being very real about the situation we are in. So we are entering what I've been saying for some time now, an age of biology. And these ages of sort of scientific revolutions are usually obvious in retrospect, and we've had them before. So in the 1890s and 1900s, we had great scientists like Curie and Rutherford and Fritz Haber who were doing pioneering work on chemistry and how to engineer chemistry. And the first major manifestation of that were the chemical weapons that were used in World War I. In the 20s and 30s, we had a whole different scientific revolution, right? We had Niels Bohr, who characterized the atom. We had Albert Einstein, Heisenberg, Max Planck, and the quantum physics movement. In fact, was the 1920s and 30s. What that led to in the 1940s was the development of nuclear weapons. In the last 10, 15 years, I would say we've had a similar revolution in biology. We sequenced the human genome. The first synthetic virus was created about 20 years ago. And just like we've had great scientific experts like Niels Bohr and Einstein, we've had our own. Jennifer Doudna and Caitlin Carrico and Caroline Bertozzi, development of CRISPR, synthetic biology. And it stands to reason, and I will argue that it is a reality, that we are going to see a whole new age of biological weapons. In fact, there's very good evidence that lots of people are working on those. And we have to grapple with that reality because that is what is coming from a global security perspective. While that is happening, as I said, I'm going to get a little dark a little fast, so stick with me for a few more minutes. While that is happening, there's another phenomenon that I want to spend a few minutes talking about, which is, as Dean Bowman said, it is likely we are going to see more pandemic threats, natural threats. In 2015, I think the first time I said in a conversation with a journalist, said we're entering an age of pandemics. So let's take a few minutes to talk about why that is. Pandemics happen when you get a novel virus against a population that has no immunity to it, right? That's the whole thing of what happened with SARS-CoV-2. New virus, no natural immunity, and you had a whole population at risk. Most novel viruses come from animals. Species jumps. That is not my way of saying I know what happened with SARS-CoV-2. I'm saying that is generally what happens. And we have seen over the last 30 years an acceleration in novel viruses affecting humans. SARS-CoV-2 is the third novel coronavirus that we've seen in the last 20 years, right? SARS-CoV-1 and MERS. And there are a set of factors that are driving novel infections, and let's talk about that. One is economic development. By the way, this is a good thing. Economic development is a good thing. 60 years ago, half the world's population lived in extreme poverty. However, there are different definitions of extreme poverty, but half the world's population lived in extreme poverty. Today, that's 8%. That is awesome progress, right? And what happens when people come out of extreme poverty? One of the first things that happens is that their diets change. When you're in extreme poverty, you eat basically whatever you can. As you pull out and become a lower middle class or a middle class person, your diet changes. And the biggest change in that diet is meat consumption goes up. And that has led to large-scale factory farming. It has led to human-animal interactions as people have gone further and further into animal habitats. And that is substantially increasing the risk of novel viruses. The second is climate change. Climate change is affecting disease vectors and where they are. Right. Third is urbanization. 100 years ago, actually throughout entire human history, humans have been a rural species. You guys did a whole session, a whole day on healthy cities. The reason it was so relevant is for the first time in the history of humanity, more people live in cities than outside of cities. And then last but not least is globalization. And with globalization, what that means is diseases that start off in one place spread very quickly globally. I remind people that if you think about SARS-CoV-1 in China, that's the original SARS, right? 2003, compare that to 2019. Domestic travel in China increased 20-fold between 2003 and 2019, and global travel out of China increased 40-fold. It's also true for India, it's true for the African continent. And what that has meant is that diseases that start off in one place spread very, very quickly everywhere. And so, if you put all those things together, it stands to reason we are going to see a lot more multinational disease outbreaks. And this is not news that anybody really wants to hear, because everybody's kind of tired and nobody wants to talk about pandemics anymore. I spend most of my time in the last 5 years, or a lot of my time in Washington or talking to policymakers, and they're like, I don't want to hear any of this. I get it. I don't want to talk about any of this. I'd much rather talk about Michigan football. But as adults, we have to confront the issues that are in front of us and have to see the world as it is, not the world as we wish it would be. So that's the depressing part of the talk. That's the part of the talk that says we have some very serious challenges in front of us, and if we're going to be adults and we're going to deal with this problem, we have to confront it head on. But there's good news here. And the good news is all of the things that have created the risks actually set up all the opportunities for us to get out of this. I believe we are entering a period of time where if we do our job right, when I say we, it's a collective we, not the royal we, the collective we all have to work on this. If we do our job right, we can manage our way through this next period of time. And I want to spend the next 10, 12 minutes talking about what does that look like? What does it mean to do our job right? So there are a lot of folks out there who say we should figure out how to prevent pandemics. As a public health guy, I'm like all about prevention, right? Love prevention. I think it's going to be really hard to prevent pandemics because the factors that are going to drive these multinational disease outbreaks are only heading in one direction. 20 years from now, we're going to be more interconnected than we are today. Economic development, God willing, will continue. Right? climate change, unfortunately, if we can potentially slow it down, I don't see us reversing that anytime soon. So preventing these things is going to be hard. Preventing biological weapons is going to be hard. Now, maybe our intelligence communities will do a good job of deterring, but the truth is, you have both state and non-state actors. What do I mean by that? Countries and bad actors working on these things. It's going to be hard to prevent all of them. So I think prevention, as much as I love prevention, is not a realistic path forward. There are other people who are like, we should figure out how to predict these things. Like, we should be able to see it coming. I don't know how to do that. Like, in 2018, I gave an interview in which I was talking about the risk of a global pandemic, and I sounded very prescient. I mean, it wasn't anything particularly insightful. I was like, I think we're going to get a global pandemic, probably a virus. And then the person sort of pushed me, and I said, yeah, almost surely an influenza virus. That was the predicted model. Turned out it wasn't. It was coronavirus. So the point is, all of us can speculate on what the next thing is going to be. It's going to be very hard for us to predict. So if you can't prevent and you can't predict, what can you do? You can prepare. And my argument to all of you is we have all of the tools we need to prepare to be effective at managing the risks when they arrive and getting through them without causing widespread health effects, without shutting down our economy, without closing down our schools, all the things that we saw. We don't have to do any of that. So let's talk about what a preparation strategy looks like, and I think there are basically about 6 or 7 things that we need to do. First and foremost, we need a surveillance system. We don't have one. And so many of us have been talking about this idea of a bioradar. If somebody launches a missile towards the United States, we have a radar system that identifies it, figures out where did it come from, and then allows us to respond. We have almost no surveillance system for disease outbreaks. Right? If a novel agent were to arrive today, let's say it got a bunch of people sick, the system we have would then figure out what it was, we could go start doing some surveillance work, and within a couple of months, we could be up and running, really tracking that thing. That is way too slow. So we need like a national surveillance system, a bioradar system, that pulls together data from wastewater, from clinical sources, from pharmacies, from Google searches. There is a way to do this that allows us to have a sense of what is happening in the community. And that, I think, is absolutely essential. Second is we need to ramp up our diagnostic capabilities. It took us months and months and months with COVID to get testing widely available, and a year plus to get rapid tests available. I think that's unacceptable, and it's also unnecessary. So a lot of what I tried to do when I was at the White House was say, how do we fix our government systems so that the next threat, when it arrives, we don't spend a whole year saying there are not enough tests. Tests, in fact, diagnostics in my mind, are like the cornerstone of how you manage a pandemic before you have vaccines and treatments, which I will get to in a second. But with widespread testing availability, you can manage a pandemic pretty effectively, right? You don't have to shut down schools. You don't have to do all of the things that we did if we had widespread testing available on day one. So we've got to build up the capability to do that. By the way, don't just take my word for it. There is a country that did this. Anyone know which country? Canada. South Korea. South Korea, and I've studied how they did it. It's really quite impressive. They had such phenomenal testing available that I'm going to tell you a quick story. It's a little bit of a side point, but it's incredible. By April, May of 2020, their entire society was open. Nightclubs were open, bars were open, everything was like cruising along. And there was one guy who woke up one Saturday morning with a fever and a cough and went and got tested and had COVID. And he had been clubbing the night before. And he had been to 8 nightclubs. By the way, that is an incredible night. I don't know if I've ever been to 8 nightclubs in one night, but anyway, he went to 8 different nightclubs. Estimated to have about 2,000 direct contacts. Saturday morning he tests, he's positive. By Tuesday, they had tested 20,000 people. And by Thursday, they had essentially isolated everybody who had been exposed and stopped that outbreak. You can imagine what one person who's contagious going to 8 nightclubs can do. And they stopped it. Not by shutting the society down, but by having great testing infrastructure. There is no reason we can't do that in our country. And we made some progress on that. We have to make more. So I think testing is really, really important. Let me talk about a couple more kind of classic medical countermeasures, and then I'm going to talk about information and community engagement. Therapies. Everybody wants treatments. We talk a lot about small molecules like Paxlovid, drugs. They take a long time and are hard to develop. The thing that's easier, is antibodies, monoclonal antibodies. And so for the scientists out there who think about this, and I've been saying this to policymakers, we have got to invest in a platform that can build up monoclonal antibodies very quickly. Because if we can do that with a novel agent, we can essentially lower the risk of death to 0, because if you can treat people very effectively, that's going to make a big difference. I want to take a minute to talk about vaccines and how we prepare using vaccines. So Washington's a very interesting place, and I'm happy to talk about how it's interesting, maybe in the Q&A. But there's a lot of magical thinking that goes on in Washington. Right? Like sort of we'll just wave our hands and then this problem will be solved. And one of my favorites is a very senior person at the White House. I was speaking to him, and I was talking about the need to invest in vaccine platforms, the need to develop like capabilities to build vaccines against agents we don't even know about right now. And he said, this all seems totally unnecessary. I said, tell me why. He said, well, with mRNA, we'll just build a vaccine in a month. I got one laugh on that. I like that. I was like, really? How are we going to do that? Well, we did that last time. And it took some time to explain how it is that we built vaccines as quickly as we did. Even Operation Warp Speed, which was phenomenal, vaccines still took a while to test and get out there. But forget the testing and that for a second. The reason we were able to build a vaccine very quickly for SARS-CoV-2 is we had spent a decade studying and building vaccines against SARS-CoV-1. We knew a lot about the coronavirus. We knew that you needed to target the spike protein. We knew that was likely to be very effective. If we get a novel agent that we don't know a lot about, the idea that we'll be able to build a vaccine within a month, that would be lovely. I think that is unrealistic. So what we need to do right now, from a policy point of view, and then I'm happy to talk about how realistic is any of this stuff, but is invest in vaccine platforms against likely pathogens. What are likely pathogens? WHO has a list of pathogens with pandemic potential, but we just got to get much better scientifically at figuring out when we identify a novel agent, how are we going to build a vaccine against it? I think we can do that. Again, I think we have the scientific capacity to do that, but we've got to work on that. Let me just talk for a couple of minutes about the last couple of things on my mind. One is about information. So one of the hardest things, I think, coming out of this pandemic, look, people often ask me, are we better off or worse off after the pandemic? Are we better prepared or worse prepared than we were in 2020? I say we're way better prepared in most areas. We have better surveillance. Our diagnostic systems are better. They're not perfect, but they're better. We've learned a lot about building vaccines quickly. We are in better shape now than we were 5 years ago. The one place where that might actually not be true is in the information landscape of our country. Right? We are incredibly divided as a country. I suspect those of you, all of you in Michigan probably got some sense of that with, did you see any political ads? Because I saw almost no political ads in Massachusetts. Yeah. Everybody I know believes that other people live in an information bubble. But they themselves, of course, are purveyors of a broad range of information, and their own views are held after careful analysis of a broad range of views. I'm sure everybody in the room believes that. The truth is, we all live in bubbles, people. All of us. The information ecosystem has so fractured that all of the information, most of the information we all consume, has been highly tailored to reinforce our very strongly held views. And we have got to find ways of breaking out of that. And there are strategies that we've got to deploy, like talking to people who don't agree with you, not as a way to bludgeon them and convince them that you're right and they're wrong, but to actually understand and engage and build relationships. I think that is just going to be really important if we're going to, it's just really important for our society, but it's going to be important if we face a health crisis again. I think there's a whole series of things that we need to do better. One of the things I tried to do when I was at the White House, so in the summer of 22, all the years blend together, we had BA5. A BA5 was one of the coronavirus variants. It was causing a pretty big wave in the South. Lots of people were dying. And I realized me standing up on the podium at the White House, telling people in Alabama and Georgia and Florida to get vaccinated and get treatments was probably not going to work. They weren't excited about what does this Biden guy think we need to do. And so a lot of the work we did behind the scenes was talk to religious leaders, political leaders, leaders in Congress from those states, and said, how do we get this word out? And I don't want to be a messenger. You be the messenger. So it is about trying to break across these lines and trying to figure out how do we get more good information. The last point I'll make on this is all of us, I think, have a responsibility of doing a better job spreading good information. Right? I really do believe the best way to counter bad information is by spreading good information, being good curators of information. And so we have a responsibility to make sure that we're not spreading bad stuff, really, and then also talk to people over Thanksgiving, talk to people in grocery stores. I'm not saying go out there and start talking to people about vaccines at Thanksgiving if it's not necessary, but be a source of good information in your community, in your life. And all of you as students, as faculty, as staff, especially those of you in public health, have a particular, I think, responsibility, but a stature that you can use to share good information in a non-judgmental, kind, thoughtful way. Last thing that I want to talk a bit about is the issue of community engagement. And I mentioned this a little bit in the way that we thought about the BA5 wave, but the real example I want to give is in what we did or what happened with the Mpox outbreak in the summer of 22. So if you all remember, there was a pretty big outbreak of Mpox, pretty much localized to a community of gay men, and we had a vaccine, and there was a lot of bad information spreading. And our strategy on so we had the tools, as they say. We had tests, we had vaccines, we had a treatment that didn't really work that well, but it worked a little. The question wasn't, can we get this under control? It was, how do we work effectively with the communities? And one of the strategies we used was to let the communities, the advocates, the activists, actually drive a lot of our engagement. So instead of the White House or the CDC coming up with information that we sent out to communities, we actually asked them, said, why don't you guys develop the information strategy? We'll work with you. We'll pay for getting it out, but you develop a strategy for how to communicate with gay men, and particularly young gay men who are not super plugged into the healthcare system. When we began our vaccine campaign, the typical way we do vaccine campaigns is we do it in CVS and Walgreens and public health departments. And lo and behold, a lot of young gay men weren't coming to those places to get their vaccine. So we asked, what do we do about this? And they're like, you should have vaccine programs set up at places where gay men go, in front of bars, at sort of large gatherings. And we did. My favorite thing of just having to switch our thinking was, we were doing subdermal vaccines that leave a little mark. And for some people that was fine, for other people it was stigmatizing. And we were doing the vaccines on people's arms. And that was one of the reasons a lot of folks weren't coming to get vaccinated. So we asked, how do we do this better? And they're like, can you switch vaccinating people to maybe to their abdomen or some other part that's not as visible? Now, we're not used to doing that, and public health workers or vaccinators had been trained to use the arm. And so we did a campaign where we basically retrained our vaccinators to use almost, like you put it on someone's thigh or on their belly or wherever they want. These are little things, but they actually make an enormous difference. And it was basically born out of the idea that we in the White House or the good folks at the CDC didn't actually have the answers for how to engage this community. And we needed to get the answers from the community. I think that is a really important lesson for all disease outbreaks, especially ones that tend to affect certain communities more than others. It's not engagement like you show up and you say, hey, here's my message, do this, please. It is, help us figure out how to do this better. And I think that was a big part of getting a lot of people vaccinated, getting Mpox under control. So let me just wrap up by saying, obviously, it's been a very difficult 4 years with this global pandemic. There is a lot of good things we learned. And there is clearly a fatigue around these issues where people want to sort of leave it behind and focus on other things, and I get that. I feel like all I did was talk about COVID for 3 years. I was excited when I could start talking about other things. But the bottom line is we are entering a period of time where these are going to be very substantial challenges, both from man-made threats as well as from natural threats. But the good news here is, with really good scientific work, with deep community engagement, with learning how to talk to each other better, I think we can manage this, and we can manage it in a way that's not going to be disruptive, it's not going to be harmful, and that is up to us. So I want to say, plead with all of you to stay engaged on this, think about what role you can play as public health people, as scientists, but I feel very confident that if we do our job right, we're going to manage this time period quite effectively. So thank you for listening, and I'm looking forward to questions. Thank you.
Terrific. So I'll take this one.
You're this one?
Yeah.
All right.
So one more round of applause for Dr. Jha. So really enjoyed all of your remarks and want to just take the opportunity to go a bit deeper with you during this segment of the program. And I want to start for you really at the beginning of the White House journey. In fact, just before. It's not every day that one receives a invitation to join the White House.
Yep.
Do you remember the day, and what was it? Was it a phone call? What were you doing? Do you have a clear recollection of what that day was like for you?
Yeah, so it sort of sneaks up on you, and I'll explain what happened. In February, I had a conversation with Ron Klain. He was the president's chief of staff. And I would talk to Ron with some frequency during the first year of the Biden administration. So it felt like just a normal conversation. And the president's chief of staff is the hardest job in Washington, by far. And he's an incredibly busy guy. We ended up speaking for 45 minutes, which felt like a luxury. And we talked. I basically told him about things I would be doing differently. He pushed back. Anyway, it was a very good conversation. And then at the end of it, he said, hey, would you ever consider coming into the administration? And I said, Ron, for God and country, anything. If there's a way I can be helpful, yeah, I'd certainly consider that. He's like, great. He's like, I'm not thinking about anything specific right now. Maybe after the midterms. I was like, okay, you know how to reach me. week and a half later, I got a phone call from Jeff Science, who was the COVID coordinator at the time. And he said, spoke to Ron, sounds like you're interested. I said, interested in what? And he said, this role. I said, that is not what Ron and I discussed, but like, yeah, like if that was a possibility for me to do something that would be useful, I told Ron, I'm game. And so then we got going on the conversation. What might it look like? There were no commitments at the time. We just talked for a while. Then I had to go through vetting, just very quickly. Vetting is like it was I had a 10-hour interview. Wow. I didn't even know I had done that much stuff in my life. And they were like, okay, so let's talk about when you were in college. I'm like, really? Anyway, we don't want to talk about what I was in college. 8 clubs in one night? I wish. And then the final thing was meeting with the president, because he decides who his senior staff is going to be. And the funniest part of that story is I got a phone call from his scheduler who said, the president would like to meet with you. What is your availability? I was like, what is my availability to meet with the president of the United States? How about any day between 6 a.m. and midnight, 7 days a week? And if it has to be between midnight and 6, I can probably make that work too. And so we settled on a time. I went in to meet with the president, and it was supposed to be a 20-minute conversation. This is classic Joe Biden. We ended up talking for an hour. It blew up his schedule, but this is just what he does. He gets into a conversation, and then and about halfway through the conversation, put his hand on my arm and said, I'd really like for you to do this. The country needs you. I need you. Would you come join the team? So, I said the only thing that came to my mind, which is I said it'd be the honor of a lifetime. And when I walked out, I turned to Ron and I said, I bet he's batting 1,000 when he does that. And he's like, yeah, you'd be surprised. Some people totally freeze and don't know what to say. So it was an extraordinary, but very fast. Like from that first phone call to basically saying yes was all about 2.5 weeks. And then like 3 days later, it got announced. And then 5 days later, I was gone. So from a Brown University point of view, like they had to find an interim to like fill in everything in days. So it was a very, very rapid process, but it was an extraordinary process. And I do think it's a once in a lifetime opportunity. I mean, we say that too easily, but this one is sort of like, hopefully we will not have another global pandemic anytime soon. Hopefully we'll have someone in the White House who will want a public health person there. We'll see.
Yeah, well, first of all, I'd like to just thank you for your service.
Thank you.
And while you just kind of described the response for you, maybe choosing your words, but a bit of a no-brainer, it was still a complicated time,
yes.
Right? In the spring of 2022, we'd made our ways through some of the challenging early days of uncertainty in the pandemic, but there was a lot that had formed already at the White House, but also by way of a complicated public sentiment toward the pandemic. And so if you can talk to me about those early days for you, how did you think about the transition? What were the major opportunities that you saw, or maybe even some of the obstacles?
Yeah, no, it's a great question. So first of all, I didn't really know what exactly I was walking into. It's not a job with a very clear job description, right? The title is White House COVID-19 Response Coordinator. So the key word in my mind is coordinator. Very quickly come to realize the agencies have enormous amount of power, and what the White House largely does, if it does it effectively, is coordinate that response across agencies. The US government is a very big, complicated organization with lots of different vested interests. The people in the Department of Commerce and the people in the Department of Labor and the people in CDC and people at CMS don't always see eye to eye on everything, right? Because they have different constituents. And so a big part of the job was like trying to get everybody enough on the same page to move the ball forward. That was challenging, but I think incredibly gratifying when we could get that done. It is true that the views in the country were already starting to solidify. There were people who by March of 22 felt like the pandemic was already over and like, why are we even doing this? And there were other people who felt like things were as bad as ever and we needed to really double down on restrictions. A lot of my thinking as I walked in, I met with the president early on once I had started, and I tried to get from him a sense of what did he want in this job from me. And one of the things he talked about there were several things, but one of them was we needed to bring the pandemic to an end at some point. There are lots and lots of books that have been written about how to respond to the early days of a pandemic. There are no books on how to end a pandemic. What does that even mean to end a pandemic? And he wanted to make sure that we did that in an orderly way. He wanted to make sure we were much better prepared. Omicron, I think, had caught everybody off guard. There was no belief that we wouldn't get another Omicron-like event. We might. How do we make sure we're ready for that? And one of the things he said was, he had an agenda of what he wanted to accomplish that went obviously beyond getting the pandemic under control. He wanted to address climate change. He wanted to address a whole set of other things. And as long as COVID was in front of people's minds, it was crowding out everything else. So a big part of the job was get COVID under control and get it into the public health world so the country could move on and tackle all the other stuff. So it was a complicated agenda. The one funny thing I'll tell you on a quasi-personal level, which turned out to be quite true, was Ron Klain, who was the President's Chief of Staff, said to me as I was coming in, he said, look, you're on TV, you're popular, a lot of people like you. Some people don't like you, but most people like you. You seem like a very reasonable guy. He said, I'm going to make you one promise. You will leave this job far less popular than you are today. I was like, you should have told me that when you were asking me to come in. And he said, no, it is just true, because once you're in, you're making decisions, and most of the decisions that come to you are like 60-40 calls. They're not straightforward no-brainers. And you're going to make decisions that are going to upset people, and they're going to be unhappy. But that is just a reality of being in the arena versus sitting in the stands yelling about what should be done. And he was right. I walked out in a very different place, but the country had been in a much different place as well.
Yeah. So I'd like to ask another question as I think about that time in your role at the White House. So, we think as a public health audience about COVID-19 as a public health crisis. But it was very complicated because it was also an economic matter. It was a political matter. It was an education matter. And so as you went about your role at the White House, did you try to offer guidance just in the public health domain, or to what degree did you have to cross over and think about some of those other dimensions as well?
Yeah, in fact, I would say most of my time was thinking about all those other domains, right? How do we make sure, and again, this is if you think about March, April of 22, it had just been after the big Omicron wave. And the idea that we might get another variant that looks nothing like what's been out there was real. And it's one of the things I thought a lot about is how do we never shut down schools again? I really felt like that was doable. I felt, and I've talked about this, I felt like as a country, we had really messed up the way we had handled schools reopening. Look, closing schools in March of 2020 made a lot of sense. We just didn't know much about it. But I believed then, and I believe now, that we could have gotten pretty much all schools open by the fall of 2020, even before vaccines were available, safely. And certainly by the spring of 2021, everything should have been open. So a big part of what I did was spend a lot of time with our friends at the Department of Education and with school leaders around the country, trying to come up with a plan for if we see another crazy variant, how do we make sure that schools sit? So most of my job was trying to apply public health knowledge to the big public policy issues of our time. The actual public health workings day to day, CDC was handling that, and obviously I was involved in that to some extent, but a lot of it was thinking about that bigger picture.
Terrific, terrific. So I should say that many of the questions that I'll pose to ASHISH came from you. So thank all of you. You had an opportunity to submit questions at time of registration. We're going to try to reserve some time at the end as well. So if you see a QR code flash above, go ahead and capture it and enter your questions. And so the next question is one that we got from several people throughout the registration process. And it's really about preparation for future disease outbreaks. And so if you can elaborate even more than during your keynote, in what ways do you think we're now better equipped to deal with the next infectious disease threat, and where do we still have room for improvement?
Yeah, it's a great question. And I try to get at this a little bit, but let me dig down a bit more. So a lot of what we did was try to build up, for instance, our surveillance system. So right now we have wastewater surveillance that captures about 60% of the country. And we're using it in a way to track COVID. We started using it to track Mpox. My view is we've got to build that out to capture. We're not going to get much above 80% because only about 75, 80% are in kind of regular, like a lot of the rural areas and are on septic systems, just stuff where you can't go out and do sampling as easily. But we've got to build that out. Unfortunately, if you look at kind of where the Congress is, they're trying to pull all of that back. So I think right now our surveillance system is dramatically better than where we were 5 years ago, but I worry a lot about whether we're going to be able to sustain it. It's interesting, again, talking about diagnostics in South Korea and the gentleman who visited 8 nightclubs. They built up phenomenal testing very, very quickly. They don't have better scientists than we do. They don't have better diagnostic companies than we do. They have certain better policies than we do, and how those tests get developed. I would argue that when I think about all the things I did not accomplish when I was at the White House that I have some regrets for, that list is also long, but one of them is I don't think I made as much progress on getting our diagnostic capabilities as built up as it needs to be. So that remains a real challenge. And then obviously we made a lot of investments in kind of the next generation of vaccines, but all of that at this point is fragile. And one of the things that we did was we worked with Congress to establish the Office of Pandemic Preparedness and Response inside the White House. Because my feeling was like this ad hoc, let's get a COVID czar, is not a way to run a country. Like you actually want a permanent office in the White House that focuses on pandemic preparedness and response. So we got that codified into law, and we have a great team working there right now. The next administration has not shown a lot of excitement about supporting that office, and they could literally just sideline that. So my point on this is you can build stuff, but it's fragile, and preparedness is an ongoing exercise. It is not a one and done. We got prepared, now we're good. We got to maintain that over time.
What about data? In your role, did you feel like you had the data that you needed? Do you feel like as we face potential threats in the future that we're in a better place than we were at the outset of COVID-19?
Yeah. The data situation is better, but it was awful and now it's just bad. No, there was consistent, the number of times I actually would turn to non-government sources to get data was quite substantial. That's unfortunate. Like the data infrastructure of CDC has been slowly getting better. There's still lots of public health departments that are on Excel and fax. We've got to figure out how to kill the fax industry. We're the public health and medicine are the only people keeping the fax industry alive. And I think it's time. If anybody gets laid off in the fax industry, I feel badly. We should find a way to compensate those people, but we've got to move along. So we've made progress there, but the data infrastructure is still really quite suboptimal. And no, it's not where it needs to be. So the question will be, how do we make progress there? There were a lot of efforts to put new investments into public health departments. Look, data, CDC is not a national data collection agency. And they do some national data collection, but most of the data we care about comes from states. And so the investments have to happen at the state level. Now, the money can be federal, but the execution of that has to happen at the state level. And that has gone slowly and unevenly. And again, I know this is a recurring theme. I am worried about what is going to happen in the next 4 years in terms of those investments. So data is the lifeblood of a response. If you don't know where things are and what's happening, you can't respond effectively.
Absolutely. So many people in the room will recognize you from even before your days as the White House, the COVID-19 response coordinator, because of your significant media engagement and activity. And I want to delve a little bit deeper into that, but I want to start by just asking you, from your role in the media or at the White House, imagine that you've dealt with some criticism. It's
just a little.
Just a little, right? And it's, as I think about many here who were on the front lines of the COVID-19 response, and to think about our students here, right?
Yeah.
As they think about their futures, the courage and resilience that you have to have, just in your lens, how did you think about the critiques that you faced and the negative feedback?
Yeah, that's a great question. So let's talk about it from the White House perspective, right? There is a bit of a mindset that people can get into in the White House of like, you're either on my team or you're not on my team. And it's actually not a helpful way to think about the world. At least it wasn't for me. And so there were a bunch of people who were very critical of many of the things that we were doing. And what I tried to do is, and I'll get to like some advice on this in a second, what I tried to do was separate out the tone and the vitriol from the substance. And often found that sometimes people didn't package it in the nicest of ways, but they were saying important things. So I had a whole group of people that I would just call. If I saw a critique of theirs, I'd pick up the phone and call them. Not to say, why are you critiquing me, man? But tell me more about that. Help me understand that better. And then sometimes, if I could, I would share the constraints I had. I get it, I want to do exactly that, but here's why I can't. But do you have ideas for me of things I can do? And I found people were very responsive to that. And the other way I engaged with the public, with experts when I was inside government, was, there were times I had to make decisions. A topic would pop up at 11 a.m., and then we were going to have a big meeting at 4 o'clock with a bunch of different principals inside the White House to make a decision. And that basically gave me about 4 or 5 hours to try to pull together my thinking and where was I going to land on this. And so often there was a group of people I would call and say, how would you think about this problem? And there were some people initially I would call who would say, oh, this is complicated, there's a lot of data, there's a lot of pros and cons, give me a couple of days and I'll get back to you. I'm like, no, I have 4 hours. And largely I don't need to hear the pros and cons. I need for you to help me synthesize and weigh in which side would you go on and walk me through the reasoning. So put all of that together, here's my advice to you about how to engage with policymakers. I believe most policymakers want to get the answer right. They just do. In Washington, Republicans and Democrats, in state houses, policymakers largely want to get the answer right. The reason academics are often not very constructive or useful is we don't try to understand their constraints. When you're a policymaker, you can't just do anything. I always remind people, I was the COVID czar, literally no power to do anything. It's the worst kind of czar, right? I couldn't tell the CDC what to do. There were things that CDC came up with. I was like, this is totally not right. And I would try to persuade, but if I couldn't, that's what we were doing. And so there are constraints you have in every government job, every policy job. And if you want to be constructive, try to understand those constraints. If you don't understand the constraints, ask. Be practical in your advice, and don't make it personal. The number of people who just attacked me for being an idiot, I'm like, okay, I may be an idiot, but you don't have to say that. Tell me what idiotic thing I'm doing. So depersonalize, engage, be practical, understand constraints. If you become one of those people, policymakers will call you all the time and get your advice. And that's how you influence the real world. And I think we don't get taught that enough in public health schools and public policy schools, is how to engage with policymakers. They really do want to know what the evidence is. but they want to do it in a way that like they can then, and they don't want to hear all the things we don't know. Okay, I get that, but like tell me what we do know, because I need to make a decision. And I think we should all, and I am now better at that than I was 3 years ago, because I've lived on the other side, and that would be my encouragement to all of you. Engage with policymakers, reach out. If you think there's a big decision coming, you're like, you may think, I don't know, who am I to give advice? Give advice, like just reach out, send a note saying, here's one way you can think about this. You'd be surprised how often people find that very helpful and will reach back.
Terrific. And so, going a bit deeper in offering expertise, but now in the public engagement domain, again, you mentioned that you did significant media activity. Can you talk about why you did so much? There are many things that you could have been doing with your time. So why you did so much, the value in your view for that kind of activity, and then what you would offer to others who might have something to offer.
Sure. So I'll just tell you a story of how it kind of came to be. Early March, I made a couple of comments to a couple of journalists I talked to. It started just snowballing. And if you remember early to mid-March of 2020, it was a crazy time and there was so much uncertainty. And at one point by the end of March, I was getting like 250 media calls a day. And I was doing about 40 media calls a day between newspaper, TV, et cetera. And my mental model at the time was, this is temporary. I'm gonna do this for a few weeks until CDC starts doing its kind of daily briefings, and then we're all gonna be good, and then maybe I'll do it every once in a while. And that is not how it all played out. Instead, the president started doing it from the briefing room in the White House, often would say things that were, let's just say, not fully accurate. And so I continued, and some of you know this, but I was also working with a lot of governors and state health departments, and it was pretty consuming. And I was just doing nonstop media for about 3 months, 7 days a week, about 14 hours a day. And then I just felt totally burnt out, and I said, I have to stop. And I started talking to friends who actually said to me, no, like maybe scale it back a little, be a bit more sane, but you shouldn't stop. Because it turns out public health begins with engaging the public, and all of the media is actually helpful to people. And part of the difficult moment of that time, and I will get to your question, this is just more of a personal story, was it was hard to get feedback. I had no idea. I wasn't interacting. It wasn't like I was doing media and then going out with people in the evening and saying, did you see me? Like I had no idea that anybody saw me ever. And the way the media stuff works is you stare into a blank screen for 4 minutes and you have a conversation with a voice, and then it's over, and then you go back to like doing whatever you were doing. And so ultimately I came to conclude that being engaged with the media was helpful, and I should continue trying to do that. The one other part of this that was important was I did throughout the whole pandemic until I went to the White House, I did both pretty liberal media and very conservative media. So I'd say between the fall of 21 till the spring of 22 when I went to the White House, I did more Newsmax than MSNBC. I don't know if you guys know Newsmax. It is clearly to the right of Fox News. I did a lot of Newsmax. They would call me, I'd always say yes. And what I said to my team was, I said, I need you to watch what I'm doing, and it's gotta be the same guy on MSNBC and Newsmax. It's packaged a little differently, but the substance of the message has to stay the same. And I felt like that was an important thing to do, and as long as Newsmax was willing to have me back. Once I went to the Biden White House, Newsmax was no longer interested. More importantly, the Biden White House was not interested in me being on Newsmax. And so things changed, which I thought is actually unfortunate, but that is the reality. But the last point I'll make on this, to your question, is I think engaging with the media is really important because public health is about engaging the public. You know, President Obama once said, famously, that public health people don't understand the public. They're terrible at engaging the public. And it turns out, I think President Obama was completely right. Like, we have got to do a better job of understanding the lives and constraints of public, that we serve, and engaging the media is one way of serving the public and the public's health. So doing that as much as possible, doing it in a nonpartisan way, doing it in a way that reaches everybody is really, really important.
So we live in an age where there's so much information for people to sort through when they're seeking guidance. To make things a bit more challenging, there's a lot of misinformation, even disinformation. And so both, from work as scholars, but also even thinking about media activity, how does this landscape change how we should think about the work that we do in terms of educating and guiding the public?
Yeah, it's a great question. So I'll put on my dean hat for a second, and I know, Dean Bowman, you think about this a lot too. I live in Massachusetts, I work in Rhode Island. These are two very blue states. And I have said to my team and to our school, we are not trying to train public health experts to just go work in blue states. Like, we need to train people to go work in purple states and red states. And that means we need to help our students understand that our country is very diverse in its views. It is very diverse in its understanding of the role of government. It is very diverse in its understanding of public health. And we have got to train our students to do a better job of understanding that diversity of views. We've got to have more faculty who can teach our students that diversity of views. And we've been working on that at Brown. It is important that we do that. On the media front, look, the media landscape is super fragmented as well. There are certain principles that I think you can take. And now I have not. When I look back at things I have done that I wish I had done differently, I think about the fact that, like, I have tried very, very hard not to turn criticism into personal attacks. And there are a couple of times, you can see it in my Twitter feed, like back in 2020, when I said a couple of things, like towards Scott Atlas, for instance, that were not just critiques of his policies, but were critiques of him. And I regret that. I haven't deleted those. I feel like I own them. I should just own it. But in general, like, try to avoid getting into personal attacks. Stop calling people idiots. Don't call people anti-vaxxers. Like, you're not going to persuade anybody by calling them names. Just, it's not how it works. Am I right? Imagine anybody comes up to you, calls you an idiot, says you're a blah, blah, blah. Like, how open are you at that point to say, tell me more about how I should change my views? You've really opened my eyes. I never thought I was an idiot, but now that I know that I'm an idiot, please talk to me. Enlighten me, right? That's just not how it works. So try to be more kinder, more understanding, more engaging on these things. I think that's a very important set of skills that we all need to get better at. And we in public health schools need to do a better job training our students in.
Terrific. So actually, let's move down the pathway of talking a bit more about vaccination. And something that we've seen come out of the pandemic is decreased trends towards getting vaccinated. And these, the numbers would suggest that it's not just an extreme view of anti-vax, but a broader trend. And as one example, in Michigan in 2017, there were 8 counties that had less than 70% of their children ages 1.5 to 3 years old caught up on their recommended vaccine series. As of summer of 2024, the number of counties that fell below this threshold, 51.
Yeah.
And this is a local example, but we see that playing out nationally. Can you talk a bit just about how you see this trend toward vaccine hesitancy and what it might mean or how it might impact infectious disease threats as we move forward?
Yeah, I mean, I hear that, and it's obviously in some ways heartbreaking because vaccines are one of the sort of phenomenal success stories of modern public health and modern medicine. So a couple of thoughts. I mean, first is if you go back to 2017 or 2019 nationally, if you look at which state had the highest childhood vaccination rates in 2019, Mississippi. In fact, there was no partisan divide, and to the extent that there was one, it was liberal California that was much more likely to be vaccine skeptical than conservative Mississippi. That has changed. We have managed to increasingly partisanize vaccines. And I think there's something, we have got to deal with that. And part of departisanizing it is, I think, kind of reaching across the aisle on these issues. If you look at those 51 counties that you mentioned, I suspect they skew more towards red counties than blue counties because we have somehow managed to tie political identity to vaccine confidence. We've got to break that. How do we do that? Look, for years we've had this attitude of just get vaccinated. Like, it's safe and effective, just get vaccinated. That just isn't going to work anymore. We are now at a point where we have to re-engage on this topic. We have to talk to people about why vaccines are what they are, how they work. There was a sense that we didn't have to do this. It was just well understood. We no longer live in that moment. All of us have an obligation to educate people on why vaccines are, in fact, safe and effective. Not all vaccines are equally safe and effective. We should own that. There are people who get injured from vaccines. We should acknowledge that, and we should talk about it and what we're going to do. Like, I actually really believe in the power of vaccines, so much so that I don't shy away from talking about their foibles, their downcomings, their shortcomings. They are not perfect. They're awesome, not perfect. And we've got to do a better job of engaging people on that, because if we're totally dismissive and not addressing their concerns, then it doesn't work. And one last point, I make this point a lot. The job of public health is not to tell people what to do. It is to help people make better decisions. Don't tell people to go get vaccinated. Help them understand why they're better off getting vaccinated. Help them make better decisions.
Terrific. So this final question will be one that we received, so I won't be talking first person, but I'll read the question. Considering 17 million Americans are currently suffering from long COVID, including myself, from the writer, what steps are being taken for research and development? What issues need to be alleviated to create an opportunity for treatments to be developed?
Yeah. I talked about things that I felt like I wish I had made better progress on. This is one of them. So let's talk a little bit about long COVID. Long COVID is not one condition. It is probably 3 or 4 different phenomena that we're kind of bucketing under long COVID. For some people, it's injury from the initial infection that causes long-term symptoms. For other people, it's immune dysfunction. For some people, it might be persistent virus or persistent viral fragments. It's a range of different conditions. Congress allocated about $1.5 billion initially. My regret on that, or it's not my regret, I didn't get to determine how that money was going to get spent. I don't think we spend enough of it focused on therapeutics and testing a whole bunch of different therapeutics. There have been a few that have been tested. Most of them have not done very well. I mean, just they haven't panned out. This is really an important unfinished agenda, and we have to put, I think, a new round of investments into trying treatments, because a lot of people continue to suffer. We do know that, like, staying up to date on your vaccines dramatically lowers your risk. The risk of developing long COVID now, de novo, is really quite low, but that doesn't help the people who already have long COVID who continue to suffer from it. And I think we just need more investments in both understanding the diseases that make up long COVID, but also trying different therapeutic options.
Terrific. Well, that's about all the time we have this morning, so I'd like to thank Dr. Ashish Jha again.
Thank you.
I really appreciated your remarks and the conversation. I feel like I walked away learning some things and helping me think even about the future. So I really appreciate it. It's now time for a break, and I want to advise you that we will reconvene at 10:30. So look forward to seeing you then. Thank you.
Thank you.
Hello, I'd like to ask everybody to take their seats, please. Marissa, stop chatting. All right. Well, thank you again to our guests. Thank you for everybody for attending, and people who are attending remotely as well. We've already had a very interesting morning. I wanted to start out with a few comments to frame both some of the conversations that we'll be having going forward today, but then also some of the some of the things that we're doing at the School of Public Health and at the university around this theme of infectious diseases and our plans. In infectious disease, I know me, my colleagues around the country, we have a lot of conversations looking in the rearview mirror lately about how things went, what things could have been different, what things could have been better. And I really would like to focus today, as Dr. Jha did a very nice job of looking forward and talking about what have we learned that we can use and how are we moving forward in this space in combating infectious diseases. So this event is one of many things connected to the IDEAS program that Dean Bowman introduced. So this is an interdisciplinary center based in the School of Public Health, includes a summer speaker series. We've had community symposiums. We've had student presentations. This is a reminder to me to plug. We have student posters today. And so we've got some really great student-led research that's going to be presented as well today. So I really encourage everyone to go and ask them a lot of questions. I know the students really appreciate me saying that. And then we've done a lot of internal and School of Public Health collaboration mixers where we try to match people with skills together and build teams and with an eye towards preparing to respond to big initiatives or programs and kind of where do we want to be in the future. So we've also had a pilot program as part of the IDEAS Center. The first round of the pilot program completed last year, and that was focused on, we had one award on building wastewater testing capacity, and then one award on doing qualitative work to understand how schools and local public health use vaccine information. So very relevant to where we're talking now about moving forward. For those of you who are affiliated with the School of Public Health, I really encourage you to watch for future announcements for pilot funds as well. So what has grown out of these public health IDEAS programs are a number of big initiatives that have launched either since the pandemic or initiatives that have really grown and changed since the beginning of SARS-CoV-2. And the one I wanted to start by highlighting is MICOM, the Michigan Public Health Integrated Center for Outbreak Analytics and Modeling. This is based as a partnership in the School of Public Health and the State Health Department, but it really is a university-wide effort. So I think we have 4 schools and colleges involved on the U of M side, and then we work both with our state public health partners in very close partnership, but then we also work with local public health and schools and a lot of other organizations. This is a direct result. Some of the teams as part of this were formed during one of the collaboration mixers, actually. And so this is a direct result of what we can do when we start to kind of talk about the future together, but in an interdisciplinary way. And some of the things that this program has done, so we're just completing our first year, which is a year of organizing and figuring out these partnerships and kind of building the basis for this work. But we do vaccine tools to kind of view vaccine uptake and patterns in hyper-local areas so that we can craft hyper-local messages and interventions around vaccinations. We have a team that does great qualitative work, goes into different communities, works with different partnerships and groups, school administrators, different organizations to see what they need, what kind of data their community needs and will respond to. And then we also are focused on emerging issues. So for instance, we've got an H5N1 working group that's thinking about, right now, thinking about how cows move and what that means for the health of people that work with cows. Some of our current initiatives right now is doing anomaly detection, so working closely with the state partners to feed the data systems into machine learning, AI, methods that will be able to quickly detect when there's something in the surveillance systems that is unlike unlike we've seen in the past. And so that's a big focus. Also participating in statewide respiratory diseases forecasting. I'm showing an example of influenza, but also being able to boil that down into the hyper-local, hyper-regional level as much as we can in our state. And then we're always preparing to respond to current and re-emerging pathogens. RSV is not an emerging pathogen, but I stuck RSV vaccine on there just because it's my pet project. Understanding that, how that works in our state as well. But we're working on making sure that we are prepared to respond with whatever the world brings us. We're really focused on the state of Michigan, but we spend a lot of time working with other states and other centers in our network as well. The last thing I wanted to highlight too is as part of this, we're not the only initiative on campus that's been building capacity and has launched since COVID began. And so MyCom is just one of it. There's also a wastewater surveillance network that's been getting bigger and integrates their data with our systems at MyCom. We partner with the genomics work being done by the Michigan Infectious Disease Genomics Center, which is funded by NIH to do genomic surveillance. And then we also integrate with CDC-funded surveillance and NIH-funded surveillance at the Michigan Center for Respiratory Virus Research and Response. And so all of these have additional collaborative teams across campus. So we're really building this kind of dynamic and responsive network to be able to respond on the ground as things change. So with that, I think along this line of looking forward and continuing to move the conversation forward, I wanted to invite our panelists to this stage, and then I'd like to introduce everybody. So we are very lucky to be joined today by Dr. Natasha Bagdasarian, the Chief Medical Executive for the state of Michigan. Dr. Juan Marquez, he is both an adjunct clinical assistant professor of epidemiology at Michigan Public Health. He's also the medical director for both the Washtenaw and Livingston County Health Departments. And then we are welcoming Reverend Horace Sheffield III, pastor of New Destiny Christian Fellowship in Detroit and CEO of the Detroit Association of Black Organizations. So let's give a round of applause to our guests and have them join us. So similar to the question and answer session before, we took questions during the registration, and I've grouped them into themes. So I've got some questions we're going to start out with, but I know there's also a QR code that will come up at some point if you wanted to add questions to the conversation as well. First, I think just to let everybody get settled in, it would be great if we could have each of you introduce kind of your experience, your expertise on thinking about infectious diseases, how they affect your communities, and what keeps you passionate about this topic and in this work. That is a big question, but what is sort of motivating you to focus on infectious diseases? Juan, I'm going to have you get us started if you want.
So my name is Juan Marquez. I'm the medical director for the Washington County Health Department, Livingston County Health Department, and in terms of infectious diseases, so I started as a medical director 6 months before COVID-19, really the pandemic, right? So I had 6 months into public health medical director. And so really, I think that my experience in public health has really been driven by a pandemic response. And so really, we've, there's been ways. So one of the things that, as we kind of come out of COVID, the COVID pandemic, we're realizing that we really need continuing opportunities to practice our response. So certainly it happened, it's been happening, but this is not the only sort of response that our health department engages in. And so one of the things, and we can talk later, is really that we've tried incorporating this model of how to respond to not just a worldwide pandemic, but even an outbreak of measles at a local school, right? And an outbreak of flu at a large agricultural facility. And so that's one of the things that we've really looked at. In terms of what keeps me engaged, part of it is, every day is different in public health. And so that is something that is interesting. And then really it's colleagues. I mean, I've had the opportunity to work with, Emily, Natasha, and folks across the different organizations. And it's been just a pleasure to work with everybody.
Hi, everyone. So my background is that I am an infectious disease physician, and I went to medical school with the goal to work on pandemic preparedness. You don't hear a lot of folks saying that, but this was really the be-all, end-all of my career, was to look at pandemics and how do we prevent them. I was lucky enough to work in other countries before I moved back to Michigan in 2020 during the peak of the pandemic. And I got to work on the front lines of COVID in Singapore, and I got to see what it was like in Dubai and in Bangladesh. And I think that those experiences and that understanding made me very passionate about communicating to the public on public health issues. As Dr. Jha was saying in his remarks, part of our job in public health is to communicate with the public. And sometimes we fall short in that regards. So that's what keeps me going and what keeps me excited, is how do we communicate these nuanced, complicated messages in really nonpartisan, non-biased way to the people that we're trying to protect. In terms of what is important to my community, I work with a lot of different stakeholders. I have worked closely with both of my fellow panelists, and I hear different concerns coming from different areas, different arenas. For my friends in the local public health and local health departments, we talk a lot about vaccines and the rates of vaccines that are declining statewide, but especially in some communities where we're just not reaching people. For my friends in academia, when I work with partners at the School of Public Health, we talk a lot about One Health and the changing human-animal interface, and how do we address the changing dynamics of infectious diseases. If we look at the rates of Lyme disease in the state, everything is completely changing as we see the climate warm up. When I talk to folks in the healthcare system, we talk a lot about multi-drug resistant organisms and things like Candida auris, which are wreaking havoc in some of our health systems right now. So there are different concerns, and sometimes I fear that these groups are not all talking to each other. But these are the things that are top of mind.
Well, what I'm presently doing really began in the context of my home. My father was a general. Dr. King was there when he was slain, first person to bring him to Detroit. And my mother was a public health nurse at Receiving Hospital. And the hospital that my father eventually became chairman of the board of and built a brand new one. And so that dynamic between what other folks were doing to us and what we were doing to ourselves played out in my home, and I witnessed it to the point where my father was influenced to become the national chair of Planned Parenthood and took up the mantle of public health. So wasn't hard for me when COVID-19 reared its ugly head to step in the fray. I had a consortium of 10 churches that we fund still to this day with 10 full-time community health workers, and say we've got to convince people without all that hype and nonsense about what's happened in the past. I mean, yes, there's been some injustices and things that were wrongly done to us, but this is a different beast. And I'll say this, that what motivates me is making death wait. Because in my community, we die inordinately, overwhelmingly too much from things that we don't have to. And it is true, and it's been proven in this past pandemic that people trust folks. We've been feeding folks. We've been doing things for folks over all these years. And this is the last thing I say. I was encouraged when we actually fought to have COVID testing at our site. We were the first one. They were doing it on 8 Mile and Woodward, but you had to have a primary care physician, which we don't. You had to have medical insurance, all those things. We had 1,500 people show up for the first day, and I knew then that this was the work we needed to do.
Excellent. Well, Reverend, I'm going to stay with you for a second. And so we've received a lot of questions through the registrations about specific diseases or conditions or things that people have on their mind. But I wanted to turn that on its head first and ask you, you've mentioned some of the major infectious disease issues that you've seen, but what are your communities most worried about? Like, Reverend, what would you say is on people's day-to-day top of mind in terms of support that they need?
I think when you think about our failure to address issues of health, it's because so many other things which ameliorate our agony are probably more important. I mean, that's why we have a program called Feeding the Working Poor. I mean, we spend $10,000 a month feeding people who go to work every day. People are worried about whether or not they're going to be able to have a decent place to live. We're blessed by DTE, and Aaron here runs that program. $2 million we just spent putting roofs and furnaces and new windows on people's homes to reduce under the guise of reducing their energy costs, but really making life more livable. So when you talk about health on the scale of what's important, and I must say that part of this too is that we work very hard to get people to understand that they have value. When you value your life, you treat your life differently. And we treat people like we value them, and so that's what they're worried about. How am I gonna live? How am I gonna make it to another day? How am I gonna keep my lights on? But in the process of us doing those things, and we call ourselves being a wedge between passing the buck and red tape, we make certain that we assess their health the moment they walk in the door. We have a clinic embedded. Dr. B's been there. We have a clinic in our building. We started. And we provide free health care for everybody, and we let them know that the most important thing, even if they're having trouble with lights and gas and food, is their health.
Juan, I'm going to actually go to you next. You serve, I hope it's all right if I characterize in this way, Washtenaw County and Livingston County have a lot of differences, both in the makeup, the urbanicity, who lives there, even the structure of their schools look like. What do you see as being, do those communities, though, when you work with the people at Washtenaw County and Livingston County, do they have similar priorities? Do they have different, what's top of mind for those folks? Yeah,
that's a good point. I mean, they're very different communities, but I think that, when we kind of look at these questions, really when you talk to folks, it's really, right, like they want to go about their, public health is the only thing I think about that day in, day out, right? For most folks, that is not what they think about. They want to go to work, they want to go to parties, they want to spend time with their family, right? And so when you think about, things that do not allow them to do that, they care about this, right? So, things like a common cold, things like an RSV infection, things that are keeping people sick, they certainly care about. But I think that one of the important things is really what I've learned over since my time in both health departments is really that people value the same things. You just have to frame it in a way that makes sense to anybody you're talking about, right? And so one of the things that we've really tried to do is really to understand, what are their values, what are the things that are important to them, and then we try to explain how, sort of the value of public health and allowing them to continue to do what they want to do. I will say that when we come across this is really, when you think about sort of like local public health departments, we are very much the implementation arm of policies, sort of policies and science, right? And so sometimes that is not very popular, right? If we were asking them not to go to school, that is not a popular discussion to have. But I think that when we try to frame it in a way about why we're asking them to, to do this, and we understand people's concerns, I think we're able to come to an agreement that, that is, I think, acceptable towards, keeping our community safe, but also acceptable for folks, who we're asking to modify their life in in hopes of keeping others safe.
And Natasha, you sort of already alluded to this in your opening comments, but what infectious disease issues keep you up at night? And are these things that you think communities are really aware of, these threats, potential threats that are coming, or do you think it's really more at a leadership level that we have to consider these things?
You know, I think Juan is spot on that folks don't really want to think about public health. It's our job to be up at night worrying about public health and putting those safeguards in place. But one of the things, and I mentioned this a little bit already, one of the things that I think a lot about is how do we communicate to folks the information they need to know? And how are we doing it in a way that is respectful, that acknowledges some of the questions that they may have, that doesn't dismiss their questions? I think for a really long time, public health has sort of conveyed this, well, just be quiet and get your vaccines message, and I don't think that's working anymore. So one of the things that keeps me up at night is how are we communicating about all of these issues to the different stakeholders? And then are we meeting people where they are? And, you know, Juan mentioned his two communities he serves that are very different, Washtenaw County and Livingston County. I've worked with Reverend Sheffield in his community. We need to really leverage those trusted messengers and leverage folks in communities who can get those messages out and answer questions in a way that is nuanced. And so that's really top of mind for me.
So Reverend Sheffield, I'm going to start with you next. It's a good segue into one of the most common questions that we received was around communication and how to become, I think many people in the public health world are thinking about this and trying to learn more. But this is complicated by the very well documented decline in trust that's been reported in a lot of spaces. And it's not just trust in health or medical authorities or professions, but also just trust, lack of trust in institutions in general. And so, Reverend Sheffield, I wonder if you could comment on that a bit to say, how do you see trust sort of changing in our modern era, and what are some things, how do we think about that? How do we think about building trust?
Well, I was going to also say that communication has been a big part of what we've done. I have a robust communications team, Stephanie, Andre Ash used to do it for the Michigan Chronicle, but what we did, we worked with Johns Hopkins University, believe it or not, to really, test some of our messaging for our community. We had to know what they were saying, so we assessed that. Obviously medical apartheid, and people bring up Tuskegee Institute experiment. All those things still carry on. I guess for me, I realized pretty early that interpersonal interaction is huge. I'm a little different. I'm actually third generation. Is the fourth generation. My daughter, by the way, was president of council, who I school all the time about this, but my grandfather was a black foreman at Ford, so my family has a certain amount of trust. I had to use that to convince pastors, 10 churches, Marvin Winans, Edgar Van, we give them $90,000 a year to this day, that they needed to do vaccinations in their churches. They needed to address the things that were being said. They needed to have people witness them having their own vaccinations. It's very difficult to ask people to do something you don't do yourself. And so we had public vaccinations in the sense that we had pastors being vaccinated in their churches. I think that we live in an era of distrust. Distrust in the church. I fight all the time to get people to come to church. And they tell me people love Jesus but can't stand nobody else, so. I mean, this is what we're chipping away at. And I think integrity, I think authenticity, I think consistency, and just being the little yeast that leavens the whole loaf. And I'll say this and I'll be done. I think my success, Dr. B, and you've been where I'm at a lot, is that I make myself available. The people who I serve see me. I'm with them, right? I'm talking to them personally. We have literally probably 30-some% of the folks that we vaccinated, we had to talk into it. We had to hold their hand and answer their questions. And that's something people don't have time to do. This is what I have for you. If you don't want it, fine. We didn't take that approach.
Fantastic. Juan, how has this impacted your work in terms of communities where you find yourself needing to build a trusted relationship, or even perhaps establishing a trusted relationship for the first time?
So this is one of the things, that, when we look at some of the things that came out of COVID, right? I think one of the things was really establishing these relationships. We've had them with our community, but I think that, as Reverend mentioned, in order for us to, outreach the community, we really had to sort of strengthen these relationships. And I think that has been one thing that we've been able to really lean into, sort of following, 2022, 2023, et cetera, where we're able to, I think, have folks that we can talk to, our organizations, have them, and kind of explain like where we are, our perspective, and then really have them help us figure out the best messaging for folks. So that's one of the things that we really looked in terms of being helpful. And I think the other thing that we've really done is that so during the pandemic, it was a adversarial relationship essentially with folks, right? Where we, there are certainly things that were very promising. Our vaccination clinics, people came, we were very happy, but by and large, we're telling people things that they cannot do and they wanted to do, right? And so that's one of the things that we have worked on to really figure out, for how are we able to help folks get where they are without telling them no, right? Instead of this adversarial relationship, how do we help them with services? So for example, right, so we might have, a family that has, for example, we had a large TB cluster locally with a Spanish-speaking family, right? Very hard to sort of figure out, who to get folks tested, to get folks treated. And one of the things that was very helpful was, not just saying, no, you can't go to work, but really, how do we help you? They're like, I got to pay rent, right? And so how do we help folks pay rent, or, make, sort of like reasonable decisions that we can all work together. So for example, if somebody works, outside during the summer, they're like, I'm not a risk to others. Why can't I go to work? I'm like, that's, what? That makes sense, right? So let's figure out some boundaries where you're keeping others safe, but you're able to carry out your day to day. And so that is one thing I think that we have worked on in both health departments to really understand, how is it that we can, have a much better relationship with folks within, again, the constraints of what we can and can't do.
Excellent. So I think one of the questions that came in, and I'm going to paraphrase, was about this difference between meeting community, the need to meet communities where they are with the resources that they have to solve problems, but then also this wide-scale disparity in the resources that are available to different communities. So there's been a lot of discussion in public health on the global scale about what responsibility well-resourced countries, I guess companies do, but countries have, and contributing to things that will benefit less resourced countries. So I wanted to ask, just more in this context, I thought this was a great question. What actions can leaders in areas with more resources do to benefit communities that don't necessarily have those resources and influence the conversation?
Are you asking all of us?
I am asking all of us, but go ahead.
Yeah, I just wanted to add one thing too, because you were talking about success. Well, my grandfather always told me speak in subject predicate form. He was found a tabernacle, and he didn't like preachers who were long-winded. So sin is evil, hell is hot, But I think what our success, and I'm going to talk about what you just asked, is that we always find a way to communicate to people in ways that make them think. So one of our phrases during COVID was illusion, delusion, ball of confusion. When people began to tell them that, they were tracing them because they were shooting things in their arms that they could be detected. It's crazy stuff. But in terms of the resources issue, we've been extremely blessed at Davo. We had to help Disparity Council. Dr. B has looked out for me in every conceivable way. But I meet today, by the way, the CEO of Crowell at 5:30. I go and talk to folks. I think there's a waning interest post-COVID in the health disparities. I mean, that was a buzzword. There was a lot of attention. I'm waiting to see whether or not that's going to continue to be true because there's such disparities that exist. Prostate cancer, I mean, amyloidosis, so many things we're affected by that really require funding. And I fought this battle. For example, we had the most successful program to reduce blood pressure. Mike Epps was one of my spokespersons. 80% of our folks reduced their blood pressure and got it under control for over a year. United Health Group funded that. Once they did the scientific panel, which by the way I always require that Dave was the publisher, couldn't get a dime. Had to go and fight for money. I mean, I've proven that we have kept people's blood pressure under control. Exercise, diet, remote monitoring, community health workers. But as soon as we prove it works, there's no money to keep it going. So my answer is, I'll raise my voice, I'll raise hell, and I tell these folks, you're not gonna invest in proving that it works and then pull the plug on me. And I'll call Dr. B, I'll call the governor, I'll call anybody, get me some money. I mean, resources is is really what it takes to make a difference, right? And if we really care, and I'll say this, you may not like it, what it really boils down to is the value we see in people. I mean, unfortunately, some folks in my community are not seen as valuable. But as a pastor, as a person who believes that every person on this earth is of immense value, I fight for those folks. And I just wish there was a magic wand. I wish there was a debit card. I could go to an ATM machine, put a 4-digit code in and get all the money I need to keep my people happy and healthy.
Natasha, what do you see in terms of how to counterbalance this disparity in resources?
One of the things I will say is that there is no one size fits all. And so what is going to work for community A may not be what works for community B. And so we've got to listen to communities. We've got to listen to people who are serving their communities and ask them what it is they need. So that's the resource part, because the resources are going to look different, but also the communication is going to look different. People have different questions. We can't minimize those questions. We can't minimize their concerns. And so I think for me, one of the big learning parts of this job has been listening to folks and being able to sit and hear what it is they need.
Excellent.
And more importantly, she's in a position to influence where those resources go. And I want to give her a hand because Dr. B has been to my site, visited my clinic. We got the neighborhood health grant. I know she had a lot to do with that. And we're able to do more than we could do without those resources. So, having people in public seats, right, who have passion and see folks and help folk makes a big difference.
For sure. Juan, is there anything you wanted to add about resources? And or I can give you another hard question.
Let's try another one. I think that's, yeah.
Yeah, so I think that I think you started to allude to this, Reverend Sheffield, that, and as I mentioned in the beginning, we spend so much time thinking about what we wish we had done differently, but there are successes that we can learn from as well. And I wanted to give each of you, starting with Juan, an opportunity to talk about some of the successes, some of the things that you are either most proud of with your role or your groups, or that you've seen other people do that we really want to take forward as models into the future. Juan, I can start with you.
Yeah, I mean, I think I mentioned the strong relationships we've built, that have really been helpful sort of moving forward. And I think that's one of the successes that I would say. And then, one other one is people don't know what a local health department does, right? So prior to the pandemic, if you ask anybody, what does a local health department do? They'd be like, I don't know. I have no idea. We have one, right? And so maybe they knew there was restaurant inspections, maybe not. But one of the things that, now there's a better awareness. Now you ask them, it's well, they vaccinate us, right? So it's a good start, right? We have more to do, but I think it's kind of also just having folks understand the role of, strong, local health department, state health department, and really, working to advocate on our, sort of on our behalf for things services that are helpful for folks, right? And so I think that has been one of the things that we've been able to, that's kind of the pandemic. As an example, one of the, in Washington County, and sort of county-based, most of the funding kind of comes through state and county. And so at a recent Board of Commissioners meeting, we had folks from all different aspects of the community. So from community mental health, from our university, from our community partners, come and speak on the behalf of the health department in order to increase our resourcing to provide services to the most vulnerable folks. And so I think that is something that would not have happened 4 or 5 years ago. And that is something that has been one of the successes that's come out of the last few years.
Natasha, do you have a success you would like to?
Juan stole my answer. I'm going to say the relationships. I think the relationships have been so key. With COVID-19, we realized that you cannot build relationships when the crisis is at your doorstep. You need to have those relationships built up ahead of time. And so since I've been in this job since 2021, I have been working on building those relationships that I hope will remain even past my tenure. Building relationships with the local health departments, making sure that we have monthly check-ins. How's everything going in your jurisdictions? What can we do for you? Making sure that we're connecting with our community organizations who are really directly interacting with communities on the ground. One of the relationships that simply was not there before COVID-19 was the relationship between public health and healthcare. And I can say this as someone who spent most of my career working in healthcare systems. I had no idea what was happening in the world of public health. I had no idea what vaccination rates look like or what outbreaks were happening on the other side of the state. And so bringing together healthcare systems and healthcare leaders and having public health grand rounds with some of my healthcare partners has been another way of building those partnerships and relationships. So I think getting to know each other, sharing the data, sharing stories is a huge success story for me.
Yeah, I think that the most glaring success is convincing folks that community people can do this. And I think we've proven through DABO and our model that we're able to, although we're not professional health, although we do have nurse practitioners and all of that, trust me, I'm not trying to take anyone's temperature. But anyone who works for me, Dr. B knows, I do a vertical slice. I mean, I know whether or not the janitor is sanitizing the bathrooms because I care that much about it. But we've expanded. We have about 17 full-time community health workers. Aaron's been trained and certified. Alasia's my newest one. Nancy's starting in January. And then we have them in local churches. And I think we've really created a model where our pastors have been very involved and hands-on, training them and connecting them to things that afflict us, and having the ability for people in their congregations to access those services. That model, I think, works. Talked about trusted servants or trusted influencers. The last part is that we also use a lot of influencers. Earthquake and Mike Epps has been huge. Mike resisted having a vaccine until he got to the point where places wouldn't let him work. He couldn't come in and make the big dollar because he was unvaccinated, and he went from not saying anything to actually coming to our site and encouraging people to be vaccinated. So we found that getting influencers also helps. People that folk listen to makes a big difference.
Excellent. So I wanted to switch gears just slightly because, in the audience, we've got a lot of faculty, researchers, students with us today. And I wanted to ask a bit about almost where do you get your information from? And what can people that are building knowledge or, doing innovative things, but in the academic space, how does that information make it to application in a meaningful way? Like, can we shorten the time between something being established or discovered and something being used in this space? Natasha, can I start with you?
That's a great question, Emily. You know, I get a lot of my information from people like you. I think that, again, we talk about the divide between, or I've been talking a lot about the divide between these different sectors, but the divide between academic public health and public health boots on the ground is real. At the national level, we have people making policies sometimes who really don't have familiarity with the settings they're making guidance for. We have academic public health doing phenomenal research, but sometimes not quite what we need in the moment, not quite with the rapidity that we might need to make some of those policy decisions, and sometimes there's not a great exchange of information. I think that we developed and nurtured some of these specific relationships during COVID that we've been able to maintain, and so now when I have a specific question about H5N1 in milk, I can call you and we can talk about quickly doing a study, but some of those relationships don't exist in other areas. And so how do we make sure that at academic institutions there is a point of contact or a relationship where we can go for preliminary information, what is someone doing already? And so I think that's an area that we still need to grow and develop.
Excellent. And
Yeah, I can talk because we've actually spent quite a bit of time trying to figure this out. So, one of the things that I care deeply about, sort of workforce development and really, training, sort of new graduates. And so, one of the things that we've done at Washington County has been to really formalize some of the work we're doing with the university. Right, we sit with sort of the university's backyard. We have a lot of relationships with individuals, but we really haven't sort of put that into a formal system. And so, one of the things that we have put together is really sort of formation of an academic health department, right? What that really means is putting together, formalizing the work that we're doing, starting with student trainee training, I guess, but really kind of with the idea that we are hoping to move forward into kind of work partnership with researchers, partnership with the university, so that they're able to get input from the health department. We're able to really think about who are the end users for a lot of our public health work. We've also done this actually just like with the MICON group, right? So with Dr. Eisenberg and Jules Gilbert here, where if there's been tools that have been developed, and one of the things that have I really appreciated from both of them is really reaching out to us and asking us, how would you use this in sort of the health department, or does this make sense, right? So I think really when you're putting your research together, or when you're doing development of any sort of tools or technology, really thinking about your end user. And just because something makes sort of works in an academic setting, it may not be practical in sort of real world setting. And so I think just having that in mind and reaching out ahead of time as you're planning your research, I think has been really very helpful for us to understand.
Well, since I'm a graduate from the University of Michigan, Masters of Public Administration, I'm always thinking about how to work smarter and gathering data. So for example, at the very onset of our work with COVID and people's reluctance, because at that time there was this myth that African Americans didn't get COVID. And so I convinced Quest, gave us $500,000 to do a serology study, and Dr. Levy was a part of that. And we came up with, I think we tested, took blood for about 1,000 folks. 33% of them had COVID. Had COVID. They still had they had the traces of it. So that proved that our community was being afflicted with COVID. So every time we do these things, the hypertension project, which we did with United Health Group, we always have some form of research that's coupled with that. And we also then partnered with St. Augustine University out of Raleigh, North Carolina, brought them in. So all the work that we do in health, we're assessing things, we're looking at things, we're collecting data, and it's informing our work. And it's really funny, Dr. B, because people are like, well, who taught you this? Who told you this? Well, I mean, I'm the kind of person, I'm not going to keep doing stuff if it doesn't work. I mean, you talked about resources. You don't have resources, it's a waste of time and money to do stuff that's not going to have impact. So I have people independent of me who evaluate our work, who do the research, and then we actually assess it in real time to make certain whether we have an impact.
So I see we're getting into our last kind of 10 to 15 minutes. So I wanted to now turn to the most common question that I've gotten, and that's, what are you doing for the next 4 years? So there, keep on.
I'm praying for the next 4 years. I'll be on my knees all day. You know.
So what are your predictions? I mean, we've had similar, we're going to have changes in the administration. We're going to have changes in resources, and it's to some degree we've seen an administration like this before, but to some degree we haven't. I think we can already see from some of the proposed cabinet appointments, it's a very different era that we might be entering. So what are your kind of predictions or implications that you're thinking about in your locus of control, in your space of work over the next few years? Juan, did you want to get started?
Yeah, I mean, I think that one of the biggest just kind of thoughts or predictions is really that we'll have change in funding for some of the services that are currently being delivered. And, I think that from our perspective, we just have to adapt to the funding that is available, and be very clear. I think if there are services that we're having to cut, explaining very clearly to Dr. B's kind of idea of communication, right? Communicating why we are cutting those services, right? And really understanding so that folks have an understanding of, the changing in funding is going to impact their day-to-day. And so I think that, we've seen this previously. We've had to either start or stop programs in response to different, funding opportunities. And so I kind of see this being the same for the next 4 years. I think, the other thing, candidly, is that I think there will be more mistrust of public health, right? And I think that all the lessons that we've done, all the things that we've been working on, we just mentioned, is going to be, twice as important in the next 4 years to really understand that we are continuing our relationships with our community organizations and our folks in our community.
Natasha, you go next.
I agree with the points that Juan just made. I think that we have to sort of steel ourselves to some of the funding cuts that we are expecting to see. But not only that, I think that there will likely be some policy changes that will have some long-lasting impacts. So if, for example, we did not have a school vaccine requirement here in the state of Michigan, our vaccination rate for the littlest ones, so those 35-month-old babies, is at around 70-ish%. And by school age, by kindergarten, it goes up to 90%. And that's because of school vaccine requirements. So if we lose those types of policies and the ability to use those types of policies, there will be a real impact on things like vaccine rates. So we have to think about funding, we have to think about the policy impacts, and then I've talked a lot about communication, but communication takes on a greater role, because if we're not relying on you have to get your child vaccinated in order to enroll them in public school, it becomes more of a, this is why we recommend vaccination, here are all the reasons, and being really nuanced about it. The reason for getting your measles vaccine is a little bit different than your reasons and the data behind getting your flu vaccine. And we see that in the rates. I was mentioning that our flu vaccine rate is around 12% in the state of Michigan. We're clearly not doing a great job of messaging. For the most recent COVID vaccine, our statewide rate is around 6%. So again, we're not doing a really great job messaging, and communication is going to take on a greater role. So I think there are hardships ahead, but we also have to see the opportunities that lie within those hardships. And one of the opportunities is to really enhance our public health messaging and use that for some of the heavy lifts.
Well, I'm 70 years old, so the next 4 years I hope I can relax a little. But what you said, Doc, was what we're doing right now. We created Detroit Community Network. God has blessed us to go out and raise $1.3 million. We're doing a couple things. One is we're expanding our current facility where you've been to. So a whole, almost half that building more will be added on, and the clinic will be on the front side when you come off the parking lot, and we're expanding that. But we're also at our new building, which we acquired, the Gabriel Shire Library, which we fixed up. We're building a radio and TV studio. It's going to be called Detroit Community Network. I have all of my dad's digitized content from when he worked with Dr. King and et cetera. But the main thing is we decided that we need to really make certain we continue to communicate with our community. That most effective part of what we did with COVID and our public health has been our communications. People tell me all over, I mean, even when I travel elsewhere, that they tune in. I got 1.2 million followers on Instagram, you know? That's why she's recording right now. And I realized, and I didn't know it was that powerful, you know? I mean, I really didn't. I mean, because most of the young folks into that. My daughter, who's running for mayor, by the way, she's jealous all the time because I have more followers than her. But the point is that, you know, I think the most important thing over the next 4 years, given all the stuff we're going to hear, a lot of which may not make sense at all, that we have to tell our own message and continue to tell people what's important. I think what happens on the local level is very important, and that's why we're building this network. That's why we're expanding our clinic. That's why we're working. Edgar Van, my dear friend, who's one of the 10 churches we fund, we pulled a group together of all the churches and said, we've got to go out, raise some money, figure out how we can continue this momentum, because we've proven that our model works. Our model works, and health is the most important thing. I'll say this and I'm done. I've been, I don't know if you know it or not, I was offered money to change my position on the ban on menthol cigarettes. I'm one of the founders of the National Action Network. I've known Reverend Sharpton since I was 19, had the first chapter outside, and like I told him, if Black lives matter, Black lungs do too. What we really got to do is organize in our community, our civil rights organizations, and all these other folks who rail against what other folks do to us, and start focusing on what we do to ourselves.
Wonderful. So I wanted to give the three of you a chance to wrap it up and focus. You know, we've got so many students here and online, and you know, we are the Masters of Public Health program. It's a 2-year program, or really more like a 1.5-year program. So a lot of them are getting ready to graduate and be our next generation of public health workers and influencers. And I wanted to give you each an opportunity, if you have any sort of parting comments or advice or requests of this coming group of students that are going to be coming into the field. So I've been starting with one every time. Reverend Sheffield, how about I start with you this time?
Well, I'm just going to leave the advice that two things that I got. One from my dad. A very difficult time in Detroit, and they were integrating schools, and my dad was responsible for that. And the teachers at a school that was half white, half black were really upset with me and antagonized me. And so the next day, I didn't want to go to school, Dr. B. And my dad asked me why. I said, well, because they're calling you names and saying things, and I'm going to do something and I'll get the words whooping in my life. Back then, you could get whoopings. Y'all remember whoopings? You remember the mental anguish of having to go get the belt and all of that? That was crazy. And he said to me something I never forgotten. They all know this, that he said, son, the only time you experience friction is if you're moving. And I want to encourage people, there's going to be some friction, but keep moving in the right direction. And the last thing is my grandfather, I was overwhelmed. I got elected early in my life to the school board at 21. And it was just so much stuff. I was in law school, and I really felt like just tossing in the towel. And my grandfather told me a story about a grandfather clockmaker who made his last grandfather clock. It was the most exquisite one he'd ever built. And he put it together, and he put this gold-plated pendulum in place, but the pendulum paused. So, oh, grandfather clockmaker, I don't know if I can do everything you're asking me to do. Tick once a second, 60 seconds an hour, 24 hours a day, 7 days a week. I don't know if I can do it. And the grandfather clock petted the poor pendulum, said, don't worry about how many ticks you got to give. Just take them a tick at a time.
To all of the students out there and all of the folks who are going to be new graduates and entering into this field of public health, I just want to say this is not the time to maintain the status quo. We are facing a time of adversity. There are going to be some challenges ahead, and this is the time to question the way we are doing things, to question the way we have been talking to people, the way we have been messaging some of our public health interventions, some of the greatest life-saving tools. How are we engaging with people on these topics? So I just want to encourage you to question it all and come up with new ways of doing things, new solutions.
I think the part I would say is I would encourage, as your kind of students are thinking about their career opportunities, like folks here are very bright, they're can do anything they really want to. I would really encourage you to think about going to governmental public health, a local health department, kind of as part of your career, or state health department. I think that there's a lot to be gained as you understand kind of like the sort of what it means to work in local health department. That even if you're going to go into research, or you're going into sort of like private industry, that you'll take a lot of good lessons from that. And I think that there's been such turnover during the pandemic, and there will continue to be turnover, that if you do like local health departments or state health departments, there will be an opportunity for you to advance your career in a way that maybe wasn't true, maybe 10, 20 years ago. But I think that is something that is true now.
Well, with that, I think that's a great place for us to wrap up. So let's join me in thanking our panelists for this wonderful conversation. I'm so grateful for this conversation. I know I learned a lot, and I feel in a different place kind of going ahead, going forward. So after this session, we are wrapping up this session, and thank you again so much for joining today. To those here in the union, and thank you to those joining us online as well. So thank you for your wonderful and attentive engagement here. So for those of us here in person, please stick around. We've got lunch, we've got a research showcase, and I warned you, you all know what to do, is find the student posters and ask them questions. And that will be down the hall in the Pendleton room. So thank you again, and I hope you here will join us for lunch.